Okay. Um, my name is Sheree Sandrock. I'm the Executive Director of the Down Syndrome Association of Pittsburgh. Thank you for joining us for our speaker series for June. We have Dr. Tarin Santamaria here with us talking about dual diagnosis and behaviors. So if you want to take it away, Dr. Santamaria.
Yes, I'm going to share my screen because I have a PowerPoint.
Great.
It said it sent you a request, Charisse.
I did say yes,
Okay.
but
Can
it
you
has,
see my screen by chance?
I cannot.
Hmm. Let me see. Oh, here we go.
There it is.
Okay. Um, so I was asked to do a presentation about the dual diagnosis of Down syndrome and autism, just a little bit about myself. Um, oh, is it letting? Sorry, I'm trying to see if it'll let me advance to the next slide. There we go. Just a little quick disclaimer. This is for educational purposes only. It's not to constitute us initiating a therapeutic relationship. If you do want to come see me, I do have information about how to pursue my services in the Down Syndrome Center. Just a little bit about myself. I have my bachelor's in psychology from WVU. I got my master's and my doctorate both from Duquesne University, where I went for grad school. By training, I'm a school psychologist, so I have my state and national certifications for school psychology, as well as my psychology license for the state of Pennsylvania. In the Down Syndrome Center, I am the pediatric psychologist. I work with individuals 0 to 24, 25-ish. I'm also a clinical assistant professor of pediatrics, which means that I do within clinic training for pre-doctoral or post-doctoral or residents as needed. I also have a private practice where I see individuals who do not have Down syndrome. Within the behavioral health clinic, within the Down Syndrome Center, which is kind of what I am called, is the behavioral health clinic. I do the initial appointment with individuals is considered a psychological evaluation. In order to be able to see me for a psychological evaluation, the individual has to be up to date with their medical appointments with one of our medical physicians. And so the recommendation is typically about once every year. So they have to be up to date with that appointment in order to schedule with me. During my evaluations also take place, or my services in general take place at the main location, as well as Pine Center, which is Wexford, and South, which is Bridgeville. The initial appointment is a psychological evaluation. That's really where I take the time to get background and historical information, do some observations of the individual, talk with the caregivers about symptoms and needs. During that evaluation, I may diagnose someone with a behavioral health diagnosis, and then we'll talk about what the appropriate treatment services may be. And this could be outpatient therapy with me. It could be a different type of outpatient therapy, or some of the more intensive behavioral health services like wraparound or ABA services. Any subsequent appointments with me after the psychological evaluation is considered outpatient therapy. And these look a little bit different dependent on the individual's needs. So this could be primarily behavioral consultation with parents or even educators, or it could be more of the traditional outpatient mental health therapy, one-on-one with the individual or including the caregivers. So those sessions are typically shorter. I would say approximately 45 minutes in duration. To schedule an appointment with me, I have our Down Syndrome Center scheduler's phone number, and Camille is our scheduler. So I'm sure that everyone here knows how Down syndrome is diagnosed. There's prenatal screenings. There's also prenatal diagnostic procedures, and then the postnatal tests. With autism, it's a little bit different. So autism is a behaviorally defined diagnosis. So what this means is we're typically not doing diagnostic tests in terms of blood work or genetic testing for the initial diagnosis, although it could be recommended after the fact. We recommend direct observations of the individual as part of the evaluation. We do clinical interviews. We review medical history. Sometimes the evaluation, when there's concerns of autism, can include psychological testing. And I have a little asterisk next to it because my position within the Down Syndrome Center does not allow for psychological testing, which may be like an IQ test or assessments like the ADOS. That's not something that's available within my role. And so that's not something that I do in the Down Syndrome Center, though I diagnose autism frequently in our population. It more is based on the clinical interview and observation and gathering information from parents. Let me see. Okay, I have to move around. The little pictures of everybody is obstructing my view of my slides. Sorry about that. So there's differences between intellectual disability and autism. So with someone who has an intellectual disability, they oftentimes have challenges with intellectual functioning, like reasoning, problem solving, and learning. There's challenges with adaptive skills. So that would be like social skills, daily living, or personal hygiene skills. And to test for an intellectual disability, we do what's called an IQ test or a cognitive test. And then there's also adaptive skills measures, which oftentimes the common ones that we hear about are the ABAS or the Vineland. And both of those scores have to be within certain ranges to qualify for having an intellectual disability. There's also clinical interviews and observations. With autism, there's challenges with communication and also pragmatic or social communication. There's difficulties with reciprocal social interactions. There's restrictive interests and repetitive behaviors. And the onset of symptoms must be during the developmental period, and they can't be better accounted for by an intellectual disability, which basically means are symptoms due to an intellectual disability, or is it a diagnosis of autism? We have to differentiate the two. To diagnose, oftentimes there's an adaptive skills measure, like looking at what can the individual do by themselves without the support of an adult. There might be a test that specifically looks at core symptoms of autism. Sometimes there's an IQ test, and then obviously the clinical interview and observation piece. In incidence of autism, so what's kind of fascinating is that according to the NDSS, the National Down Syndrome Society, they're individuals with Down syndrome, there's a 16 to 18% rate of autism. Now, there's all these different numbers out there. I've seen numbers that quote like up to from 16 to 39%. We haven't been really great at diagnosing it, and I'm going to talk about it in future slides. In the general population, the rate of diagnosing autism is about 3%. So people with Down syndrome have a higher incidence of autism than the general population has. So when we're thinking about autism and why it's higher than the general population, I'm sorry, I'm skipping ahead. A couple things to think about when we're thinking about the diagnosis of autism is that there's oftentimes what's called diagnostic overshadowing. So this is when the clinician attributes symptoms and needs that are actually related to autism to just Down syndrome. So they might say, if a parent came in with concerns and there was things that were observed, rather than diagnosing the dual diagnosis of Down syndrome and autism, they're saying, oh, that's just part of Down syndrome, which leads to not being diagnosed, misdiagnosis, and potentially missing treatment services related to it. There are a lot of overlapping symptoms between autism and Down syndrome. And then also, what's made it kind of tricky is that there have been very few standardized tests that were normed, like took into account people with Down syndrome and how this may present in individuals with Down syndrome. So oftentimes in my clinic, I hear concerns from parents. I was at a recent Down syndrome community event, and my child just didn't seem to fit in or didn't seem to be engaging with other children with Down syndrome in the same way. Maybe my child is really withdrawn or doesn't really seem to be aware of those around them, which we call being like environmentally disengaged. Parents will tell me, My kid stims very frequently, and it's hard to get them to attend to tasks because they're preoccupied with sensory stimuli or repetitive behaviors. Oftentimes, parents will tell me, these communication needs seem to be much greater than what would be expected for an individual with Down syndrome. And then also, we might see things like self-injurious behaviors. An example of this might be hitting the head on the floor, on the wall, aggression towards others, or being extremely rigid. And so I'm going to compare Down syndrome to Down syndrome and autism, and talk about like different aspects or things that we look out for. So on the right hand column is people who are just have the diagnosis of Down syndrome, not the dual diagnosis. So when we think about social motivation, people with Down syndrome typically seek out other people for interaction. They are motivated to engage with others. Eye contact tends to be really positive. Gesturing is a strength. Our individuals do a lot of coordinated gestures like looking and pointing at something, waving at others. Joint attention is like bringing things to someone else to show them or socially referencing others. So in my appointment, social referencing might be if there was like a bang, the kiddo might look to the parent and like try to gauge their reaction. Like, should I be scared of that noise or that bang? Play. Individuals with Down syndrome tend to really enjoy playing with others. They develop pretend play skills over time. There is imaginative and functional play. With friendships, they're seeking out friendships and social engagement with others and engaging in that back and forth play. There is a lot of shared joy during play, and they're socially reinforced, which means like responding very positively to being praised. So if I said, great job, woohoo, they're smile and get excited. Response to name is, when I call someone's name, do they turn and look or do they seemingly ignore or not hear? And then individuals with Down syndrome tend to be motivated to communicate with others using sound gestures or expressions. Now, the population who have a dual diagnosis, what we typically see is that the individual prefers to be alone. They prefer engaging with objects more than engaging with people. So we might say object focused rather than people focused. Oftentimes there's poor eye contact and use of fewer gestures. Individuals with the dual diagnosis may be less likely to bring items to another to show them, to get excited about and engage with them. They might not follow. If a parent pointed up at the sky and was like, oh, look at the plane, they might not be able to follow the parent's gaze or gestures. Imitation skills are poor. Again, prefers to play alone or might engage in solely repetitive play. They may appear socially disengaged, or parents will often say, my kid seems like they're in a bubble or in their own little world. There's less shared enjoyment. Oftentimes when the name is called, there's poor response to name, which again can be like no reaction at all when the name is called, not looking, not moving towards the parent, for example, if the parent calls their name. Then there's oftentimes less drive to get others' attention, but they might use the parent or caregiver as a tool to accomplish something they need. So, for example, a kiddo might bring a toy to the parent because they need help with it, not because they want to engage with the parent with the toy. One of the core symptoms categories of autism is called restrictive interests and repetitive behaviors. And sometimes we call this the RRBs. And this is sensory seeking behaviors like flapping or mouthing, sensory aversions, which might be an individual that's bothered by loud noise, for example, or certain clothing materials. Individuals who have the dual diagnosis tend to have more of these, so like in greater frequency, intensity, or functional impairment. So individuals with Down syndrome have sensory needs. They have sensory aversions, they have sensory seeking behaviors. Sometimes they have rigidity, but when there's the dual diagnosis, it's to a greater extent than what we would expect for an individual with Down syndrome alone. But our individuals do thrive with routines, and they do sometimes engage in ritualistic behavior. So that's not really a reliable indicator of a dual diagnosis. So in terms of regression, Regression is the loss of skills that were previously learned. So, in some children with Down syndrome, the dual diagnosis of autism and Down syndrome can look like a regression where the individual seems to have lost skill. And this typically happens between 3 and 7 years old. This, I just want to be really clear, this is very different from Down syndrome regression disorder. So, Down syndrome regression disorder is teens and young adults who experience a regression or a loss of skill. And it's not related to autism. That is a different syndrome or condition. So if you notice that your child, for example, was saying single words and small phrases, and then all of a sudden wasn't having that level of functional communication anymore, that would be a time to talk to your PCP or the physician within the Down Syndrome Center and maybe seek an evaluation. So, what to do if a parent or a caregiver or teacher suspects Down syndrome and autism, the dual diagnosis? First, talk to the pediatrician. Then you could talk with the physician in the Down Syndrome Center. There is a need to maybe make sure that there's medical conditions that are not contributing to some of the concerns that we have at that time. So, we need to think about sleep apnea, think about thyroid disease, rule out vision and hearing needs or potential GI issues. And then once that medical stuff has been ruled out or treated or cleared, then schedule an appointment with me for a psychological evaluation or another psychologist that has specialty in this area. So going back to how is autism diagnosed, because when this appointment with me, this is what happens. So this is the same slide as before. So I'm going to do observations of the interview or of the individual. I'm going to talk with parents a whole lot or the individual and ask about, I kind of go by category in my appointment. So I'm going to ask all about communication skills. I'm going to ask all about behaviors. I'm going to ask all about emotional symptoms. I'm going to ask about sensory needs, repetitive behaviors, any special interests. I'm going to go over medical history. Again, in my center, I don't do psychological testing. If for some reason I didn't feel like my evaluation was clear, I might recommend psychological testing, but oftentimes I feel confident in my abilities to do the evaluation. There's the American Academy of Pediatrics, when we diagnose autism, they recommend genetic testing, but we don't know a whole lot about the causes of autism yet. We believe that there's environmental and medical causes. So far, I think that there's like 1% of cases of autism that have been linked to a specific gene. There are likely more, but we just haven't discovered it yet. But it still could be helpful. So now if there is a diagnosis, if we get a psychological evaluation done and we say, hey, yes, there's a dual diagnosis of Down syndrome and autism, then we know some things that could be helpful. So these are some daily tips, like things that we can implement in daily life. So social stories are stories that can teach an individual a skill or can address a specific theme. So for example, a lot of kids that I see in my clinic have poor social boundaries or personal space. So I might look for a social story that targets that. I really love books by Julia Cook, who is an author. She has her book about personal space is called Personal Space Camp. But she has others, and they all have like great illustrations and cute rhyming messages. We might promote the use of communication and using communication in different ways. This could be sign, it could be using a talker, it could be using PECS or picture exchange system. Teaching functional communication, so that is like how the individual communicates their wants and needs. We might try to figure out if there are behaviors happening, why are they happening? What is the reason behind it? Is there a need that the person has that we have to teach in that area? We're going to support any sensory needs that the individual has. So for example, if we find out, hey, this kiddo has a sensory aversion to loud noise, then we might work on tolerating headphones in environments that are really noisy. So oftentimes individuals with Down syndrome who have a noise aversion, the lunchroom is really difficult. So we'll talk about, okay, in the lunchroom or in the gym or during assembly, maybe having access to headphones could be helpful. We have a lot of kiddos that do sensory seeking behaviors. And so I'll recommend that parents consult with their OT, their occupational therapist, to figure out, okay, what type of sensory input does your individual need? And how do we get that type of input effectively and efficiently so that we're not doing it in a less effective way or a way that appears problematic. So, for example, we have a lot of kids that seek deep pressure. And so they might like to lean up against other people, but in the classroom in the middle of circle time, their friend Susie might not like them leaning up against them, but they're seeking input. It's not like aggression or anything else, but we have to teach them, how do we get this deep pressure without using another person, for example. We might need to teach emotional regulation skills, so how to regulate themselves when becoming escalated or upset. A lot of our individuals tend to have difficulty with transitions, and this could be stopping one activity to move on to the next, or going from point A to point B. So we talk about transition supports, and then also like following another child's interest. So if the individual has a specific or restrictive and intensive interest in Paw Patrol, for example, then the parent can show interest, or caregiver can show interest in Paw Patrol, or use that to show engagement and interaction with the other. I'm going to talk about some different types of therapies that are available in our area. There are certainly others, and maybe some that I hadn't even thought of that to list, but these are some general popular ones. So a lot of our individuals do speech and OT. Oh, I didn't even list PT on here. Speech, occupational, and physical therapies. If our individuals have difficulty with sensory needs related to feeding or anything related to chewing and swallowing, there's feeding therapy. Some of our individuals do vision and hearing therapies, music therapies, or equine therapies. A lot of these are available in the outpatient setting and most in the school setting as well. For behavioral health services, there's a wide range. So outpatient therapy is considered the least intensive treatment service, behavioral health service available. This is traditionally, when we think about it, it's where the individual comes to an office to receive therapy. And again, that's that like 45-minute session. There are specific types of outpatient therapy. So that's the next bullet point. There's PCIT, or parent-child interaction therapy, and play therapy. There's other types as well, but these are common ones for our population. The next step up, which we call a higher level of care. So when a child has or an individual has more significant needs than what can be addressed through outpatient therapy, then we go a step up, and that's called intensive behavioral health services, or IBHS. There's kind of like two tracks of IBHS. There's IBHS individual services and IBHS ABA services. These are therapies that are provided in the individual's environment. So this would be home, community, school. These services have to be prescribed by a medical doctor, psychologist, and some licensed therapists. They can't be just obtained by parent calling. So you have to have a prescription or the recommendation for these services. So as part of my psychological evaluations, I can recommend the services, and they're prescribed in a very specific way based on insurance rules. So a specific number of hours per month, and then I have to list specific roles of therapists. There's also traditional ABA services. Oftentimes these are in-home or in a center or an office building. If we think about the next step up, it would be an intensity of services. It would be family-based mental health services. And then we also have medication therapy services. Our behavioral health system in Pennsylvania, there's many, many options. Sometimes they're really difficult to navigate. I oftentimes recommend our families, and really anyone that I talk to, gets a service coordinator. In Allegheny County specifically, service coordinators can be obtained when there is a behavioral health diagnosis. So oftentimes people that have only a diagnosis of Down syndrome cannot obtain this service because they bill insurance, and there has to be, it's considered a behavioral health service, so there has to be a behavioral health diagnosis. Service coordinators are they're free. It's a free service to families. They have county and insurance funding. It's a service where they help families connect to community resources. So, for example, if a family comes to see me, I do an evaluation, I diagnose Down syndrome and autism, the dual diagnosis, and I say, hey, you need to get wraparound, or the service that's called intensive behavioral health services. Families then might look at, in Allegheny County, there's 34, I think, providers of the intensive behavioral health services in our county. And families will likely have to call every single one and get on every single wait list before getting the service. And it's really hard to navigate, especially if you don't know like all the acronyms or the rules surrounding the insurance rules surrounding those services. So a service coordinator, what they could do is they can meet with the family, figure out what the needs are. They can put like feelers out there for the family, make the phone calls, and make or give suggestions on providers, or maybe see which providers have openings, and then help the family get started. So they help with things from finding a behavioral health treatment service, psychiatrist, if the family needed to get the kiddo in a summer camp, or maybe needed help with transportation or housing. Like, they can really help with many, many needs that a family may have. Some of the common agencies around, there's several, but some of the ones that I've worked with closely are Pittsburgh Mercy, Staunton Clinic, HSAO, Presley Ridge, but there's others. This is different than some of the services that are provided through ID supports. So this is more for behavioral health needs than it is ID services and supports. In terms of medication treatment, there are no medications available that treat the core symptoms of autism. The medications, when someone with autism is treated with medication, it's often treating symptoms such as like symptoms that the individual has. So if the individual with autism has anxiety, it would be medication treatment of anxiety. Or if the person has irritability, it's medication treatment of irritability. It's not medication for autism. Recently, there's been a lot of parents asking about leucovorin. Dr. Velody just did a wonderful podcast about it, and I'm not going to pretend to know all the ins and outs because I'm not a medical doctor, I'm a psychologist. So I put the link to his podcast. It was with two physicians. I'm failing to remember one of the names, but the other was Dr. Philippink, who works in our Down syndrome center. So forgive me for that. But I actually just re-listened to the podcast last night, and it was great and answers all the questions. Leucovorin is not an FDA approved medication for autism. There's no current data or evidence to suggest that it has effectiveness in the treatment of individuals with autism, Down syndrome, or the dual diagnosis. We just need more research. We need research that is based on a large population with double-blind studies. And until then, it's not going to be a medication that's recommended by any of our staff. When we think about, what do we do after there is the evaluation, diagnosis, and recommendations for treatment? I also like to make sure to connect caregivers or parents with supports and resources. So the Down Syndrome Autism Connection is a great resource. The NDSC has a DS-ASD guidebook for families. They also provide the yearly conference. This year, it's in a few weeks in Orlando, Florida. If you haven't been to the conference, we go every year as a center, and I recommend it to everyone. It's a wonderful conference. There will be sessions focused solely on the dual diagnosis of Down syndrome and autism. There's also the Down Syndrome Diagnosis Network, or the DSDN. And then I listed a few other resources. So within the Down syndrome community, there's the pamphlet. This is another link for the Down Syndrome Autism Connection. There's a Facebook group and a couple books. So when Down Syndrome and Autism Intersect is a really popular one in our community. And then a new course, A Mother's Journey to Navigating Down Syndrome and Autism. The Advocate Medical Group is another clinic in another state that oftentimes has great resources on their website. So I always go and I'll click around. So one time I think I was looking for resources about sleep apnea. So I went to Advocate Medical Group's website and I looked it up. They also have like videos and resources that feature individuals with Down syndrome, and social stories, and just great resources. So I linked one. There's a link for one that's about DS-ASD. The autistic community has resources. These are not specific to individuals with Down syndrome. They are just specific to autistic individuals. And here's a list here. And that's it. I feel like I spoke really fast and gave a ton of information. I would love to save time if anyone has questions or seeking other resources. Please feel free to shout out. No questions. Okay.
It was really great, though, Dr. Santamaria. That was so
Thank
much
you.
good information that our community is definitely going to benefit from. Um,
Thank you.
we're also, if you don't have any questions, this will be on our website, maybe even later today, and so you can go back and look through this session again. So any other questions? All right. Well, thank you, Dr. Santamaria, for your time. Really appreciate it. And thanks for everyone for joining us.
Thank you.
Bye-bye.